Very good evening to all the respected doctors attending this meeting. I am Dr. Kapil Mehta from JB Pharma, and I would warm welcome to all the respected doctors attending this meeting. And I would also like to welcome all the esteemed faculty members, Dr. Sadanand Shetty, Dr. Raman Puri, Dr. Vimal Mehta, and Dr. S.S. Iyengar, sir. Doctors, JB Pharmaceuticals has a rich legacy of almost 4.5 decades in India. And JB Pharmaceuticals is also present in 40 countries across the globe. We at JB are always committed to provide scientific platforms for scientific discussions among doctors. And in this context, we have organized this second edition of Expert Talk on the Management of Dyslipidemia in India in association with Lipid Association of India. Without much delay, I would like to introduce our esteemed moderator for today's event, Dr. Sadanand Shetty. Sir needs no introduction. He's a researcher, he's an academician, he's also a clinician, all woven into one. So, Sir works as emeritus professor at D.Y. Patil University, called a School of Medicine, Navi Mumbai. He's also director, Department of Cardiology, Sumaya Super Specialty, Mumbai. He's also CMD and founder of Southern Healthy Living Center, Mumbai. And Sir has held multiple positions in the past, like he's the president of CSI from 2020 to 22. He's also national advisor for Lipid Association of India. He's also founder of Southern G2S2 Foundation, and Sir is also the editor for Clinical Cases in Cardiology book in 2020. So, Sir, over to you to take it forward.
Thank you, Dr. Kapil Dev Mehta, and welcome all delegates for our second expert talk on management of dyslipidemia in India. Our second expert talk is going to be on these following topics. Dr. Vimal Mehta is going to talk on unmet need for further LDL lowering in India despite the statin therapy, and LAI recommendation for the use of bempedoic acid in particular. Then Dr. Raman Puri is going to discuss on management of diabetic dyslipidemia in Indians and the experts' consensus statement again from the LAI. And then we will have a interactive session for about 30 minutes or so, and then I'm going to give the closing remarks on this particular very important topic. Yeah. Next. All of us know that cardiovascular diseases remain a significant public health concern in India, contributing to a substantial burden of morbidity and mortality. Elevated level of LDL-C are a well-established risk factor for cardiovascular diseases and making lipid management a critical aspect of preventive cardiology. Next, Sarita. While statin therapy has been a cornerstone in lipid-lowering strategy worldwide, however, a persistent unmet need exists, in particular in India. Despite the widespread use of statins, a substantial portion of the population continues to have elevated LDL-C levels, putting them at an increased risk of cardiovascular events and what we call as a residual risk. Next. So, unmet need for further LDL-C lowering in India, despite statin therapy, is a very, very important topic, an important clinical problem. And LAI has given its own consensus statement, and which has appeared in JAPI last year. And so that we are going to discuss today, which Dr. Vimal Mehta is going to discuss on the topic. Next one. Of course, we know that we are capital in many things, and diabetes is one area where we have the capital. We have capital in many other lifestyle diseases. Next. Diabetes goes often hand in hand with dyslipidemia, we know, creating a unique challenge in the management of these conditions. Next slide. We have the expert consensus statement from LAI on this topic of management of diabetic dyslipidemia in Indians, and this has appeared in Journal of Clinical Lipidology USA. As a matter of fact, yesterday, Dr. Bart, one of our core committee member of LAI, was addressing the same consensus statement in USA on the same topic in National Lipid Association. Next. So, what are the precise challenges and barriers in achieving LDL-C levels among Indian patients despite the statin therapy? This is a burning problem which we are going to discuss in today's expert talks. How can bempedoic acid serve as an adjunctive therapy to bridge the gap in LDL-C management? We know we have existing statin and ezetimibe. Beyond that, how to use bempedoic acid, and what are the unique considerations in managing diabetic dyslipidemia in the Indian context, and how do these recommendations differ from global guidelines? And I always insist, or I always express, that Indian dyslipidemia, whether diabetes or otherwise, is a totally different clinical problem as compared to the Western dyslipidemia. And therefore, we as in LAI, trying to create that awareness, and my always suggestion to all the Indian physicians to use our consensus statement since we are managing Indian patients. No harm in knowing and understanding the Western guideline, but in practice we have to apply our consensus statement because they apply to our Indian patients. So, what are the implications of these recommendations for healthcare providers, patients, and the broader healthcare system in India? So, we have to create an awareness, and here I must confess the value of JB Pharma for giving us this platform, and we are doing such the educative program together with JB Pharma and LI. And I must thank in fact my privilege and pleasure to Vikas Kare VP also there, Dr. Kapil, and so many the JB team, the executives are here, Sarita, Om Prakash, etc., for giving us this opportunity so that we can create an awareness. Basically, what is the need of the hour is creating awareness. What is the dyslipidemia in India and how to treat it? So, with this few, next slide, Sarita. And we have, very distinguished and highly accomplished speakers today. Dr. Vimal Mehta is the professor of cardiology, GB Pant Hospital, New Delhi, is one of the premier institutions in the country. And Vimal Mehta is one of our nationally and international known, and a lot of the original work, and he is practically involved in most of the drug study, research, etc. And it is our pleasure, in fact, my pleasure and privilege to give a introduction of him in this today's webinar. Dr. Raman Puri, of course, he is the founder and the chairman of the LAI, and last 12 to 13 years after founding LAI, his contribution of the spreading the awareness of lipidology in the world map. Today, LAI is known all over the world. In fact, many times, many places. In fact, Raman Puri was in Sri Lanka. Few days back, he spoke to the Cardiology Society of Sri Lanka. A few months before, he was in USA. Spoke to in the American meeting of Indian doctors and so on. He's widely traveling and he's trying to create an awareness of our consensus. Most of the countries in the world, in fact, most of our conferences are very well attended by international faculty. He is the senior interventional cardiologist, Apollo Hospital, medical director, cardiac care center at New Delhi. And then Dr. Wing Commander Dr. Iyengar is is a father figure in LAI, and he is in Bangalore Manipal Hospital, and he is there from the beginning of the LAI, and he is going to be one of our panelists during discussion. So with this introduction, now I would request Dr. Vimal Mehta to start your talk, and don't worry about the time, Vimal. You can take 25 to 30 minutes, and let us make the subject, because what I was told by the organizer, by afternoon we have almost 4,300 registered delegates. Plus, it is also going to be live in YouTube. Plus, a lot of people might have joined now. So I expect, a lot of people, maybe the internists, maybe DNB, DM students, then practicing cardiologist, non-intervention, intervention, etc. So you can take your own time, because this is a very, very important, consensus what we have LA has done. Vimal, you can start here.
At the outset, sir, thank you so much, sir. At the outset, I would profusely thank you for the very generous and kind introduction which you have given me. And also, I would like to thank you as well as Professor Ramanpuri for giving me this opportunity to present this talk. So the talk, as you already said, sir, is unmet need in LDL-C lowering despite statin therapy, earlier recommendation for use of bempedoic acid in dyslipidemia management. I've been involved in various multinational, multicenter drug trials and other studies, and many of them have been lipid-lowering drug trials, and very few of them have been listed over here for the paucity of space. My talk is based partially on our recent publication in September 2022, to be exact, in the Journal of Association of Physicians of India. Achieving LDL-C goals has been a story of epic failure, not only in our country but worldwide. Epic failure is defined as complete and total failure when success should have been reasonably easy to obtain. And why we have got this certificate of failure rather than certificate of success, we have to dwell and look inside and see how we can change this scenario. There are various factors, the important one being the substantial underuse of statins and throughout the world, especially when a patient has an index event, he's started on statin, and gradually more and more percentage of patients are not on statins as the time goes by. In this 6,000 patient real world study, when the patients who were on statins, but after a year, 50% of were not on statin and only 22% were on high intensity statin, showing the dismal real world scenario. And this scenario, this is a very recent study published only a few months back, the one I showed, but throughout the number of years, from the national cholesterol, when the National Cholesterol Education Program recommended a LDL-C target of less than 70 in 2003, from that time till now, only about 20% or so patients have been able to achieve or at LDL-C goal, and thereby putting them at grave risk of future adverse cardiovascular events. If we go by the more intensive criteria of LDL-C lowering, like given by LAI, LAI is recommended a target of less than 50 milligram per deciliter in patients who have established ASCVD or who have diabetes with multiple risk factors or who have familial homozygous hypercholesteremia. Then these numbers are even lower in real world, as shown in this 1,600 patient study. Only about 5% patients have LDL-C of less than 55 as per this study, and this is a true figure and has been repeated multiple number of times. Now, so besides prescriptions, another issue is that statins have been in use practically till now. We very less commonly use other non-statin drugs, at least till 2 or 3 years back, and they reduce LDL-C by 50% or so. And many patients require more than 50% reduction to achieve LDL-C goals. Further, there is the issue of statin intolerance, which can be complete, whereby patient cannot take any dose, or incomplete, where patient cannot take guideline recommended dose of statins, is also variably reported as 10% to as high as 20 to 23% or so. Whether perceived or genuine, the risk of statin-induced side effects result perceived or genuine by physicians or by patients, it results in underutilization of statin therapy and underdosing of statin therapy. And even if patients are taking statins in a monitored setting of randomized controlled trials, Still, there is a huge amount of residual risk. As an example, in the heart protection study, which was a 20,000 patient study comparing 40 milligram simvastatin versus placebo, in non-diabetic patient, 20% patients of 5 years still had cardiovascular event, death, MI, or stroke. And if they were diabetic, almost one-third patients had event despite being on monitored statin therapy. So there is a huge amount of residual risk. And in other studies also, based on their baseline risk, like PROVE-IT was a acute coronary syndrome post-ACS patient study, 22% over another 2.5 years or 3 years will have event. So and in fact, up to 75% events, despite being on maximally tolerated statin therapy, cannot be prevented. So obviously we need more players and more drugs to take care of this unmet need. Of course, this residual risk does not pertain only to lipids. It is because of other potentially other risk factors. But here, talking about the lipid-associated risk, the non-attainment of LDL-C to the goals remains a major challenge. And as Dr. Saran Shetty also pointed out in his introduction, PROVE-IT study was the first trial which gave credence that non-statin drugs can be used to prevent hard endpoints, hard cardiovascular endpoints in patients with established ASCVD. This 18,000 patient study in acute coronary syndrome patients, and this study lasted for about 7 years or so, showed modest relative reduction of 9%. Importantly, about 1/4 patients were diabetic, and they had a marked reduction in the absolute risk. That is, ARR, absolute risk reduction was 5.5%. That is, they derived maximum benefit. And then came PCSK9 inhibitors. Although they have never been used more extensively because of the cost issues. However, these studies have a lot of teaching value because they, by the use of these drugs, we were able to achieve therapeutically ultra-low LDL-C levels. As shown in this 27,000 patient 4-year study in which we are also part, less than 25 milligram per deciliter LDL was achieved in more than 40% patients. And importantly, both patients with evolocumab, both the groups were on high-intensity therapy, statin therapy as a baseline, such that over a period of about 2 years, a median LDL-C of 30 milligram per deciliter was maintained. This was unthought of before the advent of PCSK9 inhibitors. Importantly, even with ultra-low levels, there was no evidence of any harm. In fact, the cardiovascular endpoints continued to decrease in patients who had achieved lower LDL-C levels, such that 2% patients who achieved LDL-C of less than 10 had 10 times more relative reduction compared to those who had achieved LDL-C levels between 70 to 99. And this showed that there is no nadir or no lowest level below which no further benefit cannot be achieved. I mean, the lower, the better. And this benefit is achieved benefit is much more in patients who have higher baseline risk based on the number of risk factors and comorbidities, as shown in multiple studies. For example, this is a sub study from the PROVE-IT trial, and this is from Odyssey outcomes. The more the risk, more the comorbidities, more the extent of atherosclerotic disease, more the benefit of further lowering of the LDL-C levels. And for this, as I stated, statins are not enough. Earlier in 2016, and subsequently also gave these charts, major ASCVD risk factors, so that other high-risk features, etc., so as to be able to risk stratify the patients that what is the possible what is the LDL-C goal level which is to be achievable. For the today's talk, it is important to note that all AFCD patients should have LDL-C level of less than 50, and certain patients who have established ASCVD are at even higher risk based on the presence of other risk condition, comorbidities, and risk factors. So more the risk factors as listed over here, along with ASCVD, a goal of less than 30 milligram per deciliter has been recommended so as to further reduce the risk of ASCVD events. So here comes another drug, which is a relatively new entrant, that is bempedoic acid. It's a ATP citrate lyase inhibitor. In a 6 lakh patient Mendelian randomization study, which was based on the genetic scores which were calculated for various enzymes which are involved in the lipid metabolism and their loss of function of these enzymes, what the authors reported was that for every 10 milligram decrease in LDL-C cholesterol levels, there was 18% relative reduction in the major adverse cardiovascular events. That is, these genetically lower levels. And importantly, whether the levels were lower because of the loss in the ATP citrate lyase enzyme or HMG-CoA reductase, it didn't matter. Whichever enzyme loss of function was there and the cholesterol levels were on the lower side, the subject derives same amount of benefit. In fact, patients who had polymorphisms in more than one gene and thereby affecting more than one enzyme derived almost double the benefit. So this was one of the important bases and corroboration that ATP citrate lyase inhibition will be beneficial. Therapeutically, this enzyme is inhibited by bempedoic acid, which is a prodrug, and it requires conversion by very long chain ACL-CoA synthetase 1 enzyme. This enzyme is present only in the liver and is not present in the skeletal muscle cells. And because it is not present in the skeletal muscle cells, so thereby the muscle symptoms theoretically also should be very minimal because there is no active compound to act on the enzyme. This enzyme, ATP citrate lyase, is 2 steps ahead of HMG-CoA reductase enzyme, which is blocked by statins. Now, therefore, and ultimately, there is reduction in the endogenous production of cholesterol. Liver is starved of cholesterol when this drug is given, and thereby the LDL receptor upregulation, which are present on the surface of liver, occurs, or the surface of hepatocytes are there, occurs, and such that more LDL-C is taken from the bloodstream and thereby decreasing the blood levels of LDL-C. Because this enzyme is present 2 steps above the HMG-CoA reductase in this enzyme chain. So obviously, if both drugs are given simultaneously, then the activity of this enzyme or the benefit in LDL-C lowering will be less, as we will see. It is an oral 180 milligram tablet. It has a relatively longer half-life of 15 to 24 hours. Hence, it is given daily. Its bioavailability is not affected by food, and the dose is same regardless of the age, gender, or race or weight of the subject. And it's a protein bound, and importantly, it is metabolized by glucuronidation and not by the cytochrome P450 enzyme. It is excreted, 2/3 is excreted in urine and 30% in feces, meaning thereby that in mild to moderate renal or hepatic impairment, it can be given. The drug has not been tested in end-stage renal disease or end-stage hepatic disease and hence must be avoided. It is a weak inhibitor of organic anion transporter 2, which is present in various body organs, in intestine, and importantly in the kidneys. Because it interferes, because it inhibits this enzyme, and these are important for the excretion of uric acid, so uric acid levels may be raised. in these patients who use this drug. As I said earlier, because it is not metabolized by cytochrome P450 enzyme, so it has fortunately few relevant drug interactions. It does not interact with warfarin. Only thing is that with two statins, simvastatin and pravastatin, the levels of these two statins increase about twofold if they are given simultaneously with bempedoic acid. Hence, patients who are on these statins, in any case, they are not easily available in our country. In case somebody is there on, then he should be better switched to atorvastatin before switching before adding bempedoic acid. In any new drug program, the drugs are first tested in patients in whom there are practically no options or minimal options. Same was the case with bempedoic acid. And obviously, initially, the studies are first safety studies and then efficacy studies. So these two studies, Clear Tranquility and Clear Serenity, were small 12 to 24-week studies in small number of patients to see they were proof of concept studies, whether on phase 3 studies, how this drug will behave. And they included, we'll go into the results. And then once results were satisfactory, then two large studies occurred: Clear Wisdom, which included 800 patients, and Clear Harmony in about 2,000 patients. And in most of these studies, especially in the above two, almost all patients had established ASCVD. And in all these four studies, patients had LDL-C level of more than 70, and in some studies, more than 100. As an example, in the initial part, in the Clear Wisdom study, which included about 800 patients who were randomized in 2:1 fashion, that is, two patients of bempedoic acid compared to one patient of placebo overall, resulting in 15% reduction in the LDL-C levels. All these patients, as stated over here, were on the maximally tolerated lipid-lowering therapy, that is statins. It is important to note that patients who are not on statins had about 25% reduction in the LDL-C levels versus 15% who are on statin, as was the case in majority. Importantly, whether the patient had exposure to low to moderate intensity statin or to high intensity statin, the efficacy of bempedoic acid decreased by about 10% or so numerically, as seen over here. And the reason, as I showed, was because both the enzymes are in series. Clear Harmony study was extended. It was 52-week study, was extended by another 1.5 year open label extension to see whether efficacy was maintained. And it was seen that there was no waning of the efficacy over further 1.5 years. As stated earlier, when given alone, that is either given without statins, then about 23 to 25% reduction in LDL-C occurs. If given with statins, either low or high intensity, the further reduction in LDL-C is about 15% or so. Important point, if there is remembrance issue, one can say that estimate as well as bempedoic acid alone result in similar kind of reduction in the LDL-C by 16 to 18% or so. A triple study of small study where all three statins plus STMI plus bempedoic acid showed there was about 65% reduction. As far as adverse events are concerned, there was practically no difference in the adverse event between the two groups. Overall, only issue was that uric acid was minimally raised by 0.7 milligram per deciliter. Small, very small 0.2 milligram per deciliter reduction in the hemoglobin was observed, and otherwise there was not much issue with these bempedoic acid. Only 10 cases of tendon rupture occurred, that were also in two wisdom and harmony studies, which were long-term studies, and these patients had other risk factors for tendon rupture, and this has not been corroborated further. HDLC, which is supposed to be better, although it is marred in controversy, nevertheless, HDLC was decreased by about 6 to 7% in all the studies, including the clear outcome study, which I'll be talking about in a short while. No effect on triglycerides. There was about 25% reduction in HSCRP levels. However, in a subsequent study, IL-6 levels, etc., there was no change. So the importance of this finding is still debatable. Another important thing was that risk of new onset or worsening diabetes in the pooled analysis of the 4 listed randomized trials showed that incidence of new onset diabetes was significantly less. Also, the worsening of glycemia was also significantly less in patients who are on bempedoic acid, as shown over here. Onset of diabetes was decreased. Patients who are pre-diabetic were less likely to become frankly diabetic if they were on bempedoic acid, as per the meta-analysis and combined analysis of the 4 listed trials. Now, these were relatively smaller trials compared to the recently published clear outcome study, which was about 14,000 patient study. And this study assessed bempedoic acid versus placebo in patients who had established disease or who are at high risk for cardiovascular disease and who were statin intolerant and had LDL-C of more than 100. So these were statin intolerant patients. Mean age was 65 years, equal distribution of gender, about 50% females. Mean LDL baseline was 139 and about 45% were diabetic. Importantly, 22% were on very low to low dose of statin, meaning equivalent to 10 milligram of atorvastatin. And SMI was used in only about 11%, despite them being on being statin intolerant. The LDL-C reduction at 6 months was 21%. And this 21% reduction in the LDL-C level over a 40-month period resulted in about 13% relative reduction in the major adverse cardiovascular endpoint, which was a composite of cardiovascular death, MI, stroke, and cardiovascular revascularization. And a harder 3-point MACE, which is death, MI, and stroke, was reduced by 15%, which was almost similar to the studies, PCSK interest studies, where it was about 20%. Ischemic endpoints were predominantly decreased. Coronary ischemic endpoints, MI reduced by 23%, revascular reduced by 19%, 1 minus head-on ratio, that's how you calculate it. Fatal and non-fatal stroke was non-significantly reduced. That is, they were trend for reduction, but because the line of unity was crossed over here, it was not significant. Again, as I said, coronary endpoint was reduced, so hospitalization for unstable angina was also reduced. No decrease in cardiovascular death or death, perhaps because of the relatively shorter duration of the study. And as I said, the compared to other non-statin therapies, the benefit was supposedly equivalent. Coming over to the incidence of the signal of whether new onset diabetes was decreased or not, this was not statistically significant in this larger study. However, there was a signal that the onset of new onset diabetes was relatively less. However, this was a trend. As you see over here, the confidence interval 0.8 through 1.09, line of unity is crossed. So this was not significant. However, numerically, the number of new diabetic patients was less. As shown in the previous 4 randomized trials, the HDL-C reduction was also there. What is the clinical significance of it? We do not know. Side effects, importantly, similar side effects, except two gout and polylithiasis were increased, significantly increased in the patients who are on bempedoic acid. And we know that polylithiasis has been reported also with estimate also, but nevertheless, only 11% patients were on estimate. No increase in myalgia, which is a major problem with statins. The drug was approved in 2020 in Europe and in US, and in India it was approved in 2021. Coming out over to our algorithm, we categorically state that as far as ACS is concerned, we categorically state that, for example, in acute coronary syndrome, all patients at admission during the triage, when samples are sent for their cardiac enzymes, LFT, KFT, etc., at same time, extended lipid profile, including LPA, should be sent in each and every patient, and all patients should be starting on high-intensity statin plus STMI. And based on our experience, many patients will still not be controlled on it. Once the report is available and LDL-C levels are not at goal, then such patients should be added with another drug, and bempedoic acid is a attractive alternative at this point of time. And these lipid levels should be repeated at 2 weeks in ACS patient, at 4 weeks, and patient should be triaged, and LDL-C goal should be achieved. And this is what has been recommended by LAI. And in short, I have stated all these points, and LDL-C goal should be achieved in all these patients, and there are decreased rates of new onset diabetes, as was a signal earlier on. The LAI recommend that in patients who have established history of gout, they should not be started on bempedoic acid, and those who have borderline levels, this should be explained, they should be a shared decision, and so on. Just to give a small example as a last slide, how to calculate what is the LDL-C goal, because we talk in theory and forget about it. Let's say we have a LDL-C value at the time of admission, whether it is for ACS or otherwise, or in a patient who has diagnosed as ASCVD. We determine the risk category based on LAI algorithm and calculate the absolute percentage reduction required of LDL-C. And we know that high-intensity statin reduce LDL-C by 50%, high-intensity LDL-C by 65%, triple combination reduced by 70 to 75%, and so on. To give an example, let us say this patient of 45 years old male who has history of smoking and hypertension, but no history of diabetes, present with acute MI of 1 hour duration. He started on high-intensity statin plus STMI. His waist circumference is 101. His blood tests are sent at admission for extended lipid profile, and he undergoes angioplasty while we are awaiting for result, and so on. His LDL-C comes out to be 140. So this fellow, as per our algorithm, has 3 major risk factors, that is age more than 45, cigarette smoking, and high blood pressure. So he comes in the extreme risk category A. And but also he has, even if he does not have increased risk, he comes in categories. So his LDL goal is less than 50. So absolute LDL reduction requires 90 milligram per deciliter, 140 minus 50, which was his baseline level. So percent reduction required is 64%. So he has been prescribed earlier on high-intensity statin and STMI at admission. So we'll continue with this and repeat after 2 to 4 weeks. If 2 weeks, if he's ACS, if he's not non-ACS, routine stable patient at 4 weeks, and if goal is not less than 50, then we will add bempedoic acid. That is the way to go. Thank you.
Thank you, Vimal. It was very clear and transparent talk. And we have some queries maybe during our panel discussion letters. Now I would request Dr. Raman Puri to start his talk. The diabetic dyslipidemia is another area where we require a clear consensus for the people to, particularly in India. And Dr. Raman Puri, you can start your talk. Yeah. No, unmute. You're not.
Unmute yourself.
Unmute, yeah. Yeah.
And am I audible?
Yeah.
Okay, so thank you, Sadanand, and respected Dr. Iyengar, moderator. I'm going to talk about management of diabetic dyslipidemia in Indians. Expert consensus statement from LAI, as Dr. Sadanand has already told. We published it a year back. And now coming to the burden of diabetes in India, the prevalence of diabetes has increased from 7.1% to 8.9% from 2009 to 2019. And we expect 125 million diabetic patients by 2045. Unfortunately, half of the patients with diabetes in India are undiagnosed. Remember, 70% of patients with diabetes, they die of cardiovascular disease. There are some unique features of diabetes in India. One is the younger age of onset. On average, Asian India develops diabetes between 25 to 34 years of age, which is about 10 to 20 years earlier than the Western population. Not only in the younger age, we have a highest prevalence of diabetes. This is based upon a multinational study from 11 countries. And also the age of peak prevalence in diabetes occurs about 10 years earlier among Asian Indians as compared to Chinese and Japanese individuals. This is an important study from United States about difference in risk factors between different ethnic groups. If you look into South Asian versus Native American, the prevalence of diabetes and metabolic syndrome is higher in South Asians as compared to Native Americans. And if you look into low HDL, it is more common in South Asian as compared to Native Americans. And high triglyceride and ApoB to ApoA ratio is also significantly more in South Asian as compared to Native Americans. And if you look into the LDL cholesterol, that's almost, it looks to be similar between the two ethnic groups. And if you look into BMI, BMI is much higher in Native American as compared to South Asians. Now, this triad of high prevalence of diabetes and metabolic syndrome with BMI, which is towards the normal side, in the lower side rather, and high prevalence of atherogenic dyslipidemia. These three triads actually makes South Asian phenotype. So Asian Indians, they belong to the South Asian phenotype, which is characterized by elevated body fat mass, and there is a higher waist circumference, higher waist to hip ratio, there is more visceral fat, and there is high incidence of insulin resistance with atherogenic dyslipidemia and increased risk of type 2 diabetes. And another important feature of Indian diabetes is that the progression of pre-diabetes to diabetes is much higher in Indians, about 14 to 18%, as compared to 2.5% in the United States, suggestive of more aggressive diabetic phenotype in Indians. 9 out of 10 diabetes in India, they are having evidence of atherogenic dyslipidemia, more in female as compared to male. It's not only that adult or diabetic patients have high prevalence of atherogenic dyslipidemia. This is a study done by LAI in 2015 in 2,500 school-going children in the age group of 14 to 18 years. We found that there was 44% prevalence of low HDL and 45% prevalence of high triglyceride in these school-going children with LDL cholesterol around 12%. So that shows that the insulin resistance is that starts somewhere in the second decade of life, and that is what we have. This is the lowest age we have, documented atherogenic dyslipidemia, and this probably may be one of the reasons why in India we have high incidence of premature coronary artery disease and also the premature or early onset of diabetes as compared to other ethnic groups. In addition to that, it has been found that those young diabetic patients less than 40 years, they have high prevalence of ASCVD risk factor, and we all know that this ASCVD risk factor we are responsible for initiation of atherosclerosis and progression of atherosclerosis. If we look into the 10-year risk of cardiovascular incidence in patients who are pre-diabetic and metabolic syndrome, we can see that patients with impaired fasting glucose has 29% higher incidence of CVD and 42% higher incidence of CSD as compared to normal fasting glucose. And if you look into the metabolic syndrome, the person without metabolic syndrome, if we compare with patients with metabolic syndrome, depending upon the number of the components of metabolic syndrome, the risk of CVD and CSD increases. And if somebody has 5 components, the incidence of heart CVD and CSD increases by 6 to 7 times. And we all know that there is 5 times more chances of these metabolic syndrome patients getting cross to diabetic patients. They become diabetic. So this means that even in pre-diabetic state and even in patients with metabolic syndrome, the subclinical atherosclerosis process has already started. So by the time patient becomes diabetes, they do have evidence of subclinical atherosclerosis. There is a study from South India, it's a Chennai urban population study, but that shows that proved rather that even in impaired glucose tolerance, 15% of these subjects had underlying coronary artery disease, which became 21% once the patient became diabetic. This is a recent study which was published again from India, published in June 2023, and it was found that younger diabetic patients had much higher risk of cardiovascular disease as compared to those who are older, means more than 54 years of diabetes. Why I'm stressing upon the age in this particular, all these my slides, is that this is one of the points where we differ from most of the international guidelines. This is the CVD mortality in India. We see that there is a increasing trend in CVD mortality. It has gone up by 41% from 1990 to 2015. And insulin resistance probably plays an important role because it's an insulin resistance which leads to impaired fasting glucose, which leads to pre-diabetes, diabetes, metabolic syndrome, atherogenic dyslipidemia. So probably the basic culprit is insulin resistance, which is responsible for increase in CVD mortality and increase in premature coronary artery disease in our country. Now, looking into all these unique features of Indian diabetes, LAI strongly recommend that we should treat diabetic dyslipidemia aggressive in Indian diabetic patients, even if they do not have documented ASCVD. Rather, we should start treating dyslipidemia on the day it is diagnosed. This is again a point where we differ from most of the international guidelines. Now, coming to the objective of LAI recommendation for management of dyslipidemia in diabetes, the objective is very clear. We want to reduce the cardiovascular morbidity and mortality. And there are 2 main reasons why there is increased mortality, incidence of cardiovascular disease in diabetes. One is the delay in the diagnosis of type 2 diabetes. As I said, 50% of they are undiagnosed. And second is the undertreatment of dyslipidemia. Though there are excellent recommendations from societies globally for the management of dyslipidemia and diabetes, but in view of the unique features of type 2 diabetes in the Indian population and increased cardiovascular risk in Indian population, we need specific guidelines for the Indian population. That is actually the reason behind why we went for a series of 165 webinars in 1 year from 2020 May to July 2021, and we came out with an expert consensus statement which was published in 22. Now, coming to the LAI recommendations for the treatment of diabetic dyslipidemia, remember, according to LAI, the primary target is the LDL cholesterol. Co-primary target, as important as primary target, is non-HDL cholesterol, and the secondary target is an ApoB. Now, the patients of diabetes can be divided into 2 groups: diabetes without ASCVD and diabetes with ASCVD. Those patients of diabetes with no target organ damage or one or no ASCVD risk factor out of these 5 ASCVD risk factors, they will be classified as an high-risk group, and the LDL cholesterol goal recommended is less than 70 milligram, non-HDL less than 100 milligram. And those who have target organ damage or two or more ASCVD risk factor, they are classified as a very high risk group, LDL cholesterol goal of less than 50, and non-LDL cholesterol goal of less than 80 milligrams. Those patients of diabetes with ASCVD, if they do not have target organ damage or one or no major ASCVD risk factor, they are classified as an extreme risk group category A, where the recommended LDL cholesterol goal is less than 50 milligram and the optional goal is less than equal to 30 milligram, and correspondingly non-LDL cholesterol is less than 80 and less than 65. Those patients with diabetes with ASCVD plus target organ damage or two or more major ASCVD risk factor or polyvascular disease, they are classified as category B, and the goal of LDL cholesterol is less than equal to 30 milligram, and non-LDL cholesterol goal is less than equal to 60 milligram. Now, how to achieve these ultra low level of LDL cholesterol? Dr. Bimal has very nicely explained in his last slide, and it's just I'm going to repeat it. Is that if you know what is the basal LDL cholesterol, what is the target LDL cholesterol required, you can always calculate the percentage reduction of LDL cholesterol required. Now, as Dr. Vimal has already told, moderate intensity statin reduces LDL cholesterol by 30%, high intensity statin by 50%, and high intensity statin plus ezetimibe by 65%. If you require additional LDL cholesterol lowering by 20%, you can add either bempedoic acid or bile acid sequestration, depending upon the availability. And if you require more than 20% LDL cholesterol reduction, one should consider PCSK9. But while using PCSK9, it has to always be a shared decision, and it becomes a very useful drug if the lipoprotein A is also elevated. Now, based upon this, you can always decide what combination of lipid is required. Now, what should be your treatment strategy on day 0 or week 0 of diagnosis of diabetic dyslipidemia? Depending upon LDL cholesterol lowering, the patient may require moderate intensity statin, may require high intensity statin, may require combination of high intensity statin plus ezetimibe. Few may require high intensity statin plus ezetimibe plus bempedoic acid, and very few will require PCSK9 in addition to high intensity statin plus ezetimibe. This is based upon what percentage of LDL cholesterol reduction you require. If the triglyceride is more than 500, you start fibrate the day you diagnose diabetes. So this is your treatment on the day of the diagnosis of diabetes. And now coming to week 4, if you start multiple drugs on day 1 of diabetic diagnosis, by week 4, majority of patients will achieve the target because you have used the combination based upon what percentage of LDL cholesterol reduction is required. But if, for example, the goal is not achieved and the patient was on moderate intensity statin, you can always jump to high intensity statin. If it was on high intensity statin, you can add ezetimibe. If it was already on ezetimibe, you can add bempedoic acid. If it was already on bempedoic acid, you can add PCSK9. Remember, it has to be a shared decision. And if he was initially on PCSK9, still required additional LDL cholesterol lowering, you can add bempedoic acid. And if the triglycerides still remain more than 150 milligrams, despite fibrate, you can add icosapentaethyl 4 grams per day. Now at week 8, if the goal is still not achieved, which will be very unusual, then you can go for additional drugs of bempedoic acid or PCSK9. And with these practically 3 or 4 drugs, almost all patients will achieve LDL cholesterol goal. And since we have already started fibrate and icosapentaethyl, and we'll be able to achieve non-LDL cholesterol goal and FOP. Now, if the patient fails to achieve LDL cholesterol target despite all these 4 lipid lowering drugs, one should rule out familial hypercholesterolemia, which is, of course, a genetically controlled increased level of LDL cholesterol. And also, you should rule out lipoprotein small a. Of course, we have already done lipoprotein small a, but that may be responsible for your resistance to the treatment as far as LDL cholesterol target is concerned. But make sure about drug and we should not be taking the drug so that we should not come to a conclusion that patient has not, these 4 drugs are not effective in bringing down the LDL cholesterol target. Now, coming to those patients of statin intolerance, at week 0, you can always start with ezetimibe plus bempedoic acid, but because it normally reduces LDL cholesterol by 35 to 40%. But if you require additionally more greater reduction, you can always add low or very low dose statin, which can be 2.5 milligram of rosuvastatin or 5 milligram of 5 to 10 milligram of atorvastatin. And if at week 4 the LDL cholesterol is still not achieved, you can add PCSK9. Now remember that these PCSK9 and bempedoic acid will be required mostly in patients who are in extreme risk group category A or B, because here the target of LDL cholesterol is much lower. So the percentage reduction of LDL cholesterol required will be much higher in these group of patients as compared to those patients in which high risk group where the target is less than 70, or a very high risk group where the target is less than 50 milligrams. So these 4 drugs will be mainly required if if required, will be in patients who are in extreme risk group category B or category A. Now, question is that why we are talking of combination, where most of the international guidelines, which I'll be discussing panelly, they recommend either moderate intensive statin or high intensive statin to all patients, giving some, in their recommendations. But remember one thing, as I've said, that all patients have different baseline LDL cholesterol. Most of these patients have different targets. So the percentage reduction of LDL cholesterol required will be different in different patients. So you cannot start with a fixed combination, because that is not going to achieve different type of LDL cholesterol reduction, percentage of LDL cholesterol reduction. So you have to decide in the combination of lipid lowering drug, LDL cholesterol lowering drug, so as to achieve those targets and to achieve those percentage reduction of LDL cholesterol. But because time plays a very crucial in the progression of atherosclerosis and subsequent cardiovascular events. So we have to be aggressive and we have to bring down the LDL cholesterol to the goal at earliest, preferably by week 8. This is the algorithm which I've already explained to you in detail. So, but this is algorithm, you can always keep this with you. But during treatment, you have to make sure that all modifiable risk factors are controlled. Diabetes is controlled adequately, because if diabetes is not controlled, it will be difficult to bring down non-HDL cholesterol and triglyceride to the normal range. And one should be aggressive in lifestyle intervention. And if possible, we should use SGLT2 inhibitor and GLP-1 receptor agonist in these patients when we are treating diabetic dyslipidemia. Now, coming to the justification of these recommendations, and the only trial which was also stopped prematurely because there was a significant benefit in reduction in cardiovascular event was the CARDS trial, which was published in 2004, where 10 milligram of atorvastatin in patients with diabetes, it reduced events by 37%. So the median duration of this trial was just 3.9, because once the benefit was so much, then the investigator thought that it will not be ethical not to give benefit of atorva to those patients who are on placebo. So this is a very positive trial. And if you look into all American Diabetic Association and other trials, where age 40 is the age where to start treatment is based upon this trial, because the patients in this trial was in the age of 40 to 75 years. Now, coming to need for an extreme risk group in patients with diabetes, remember at any level of achieved LDL cholesterol, any level of diabetic patients, diabetes associated with the ASCVD increases cardiovascular.
8:30 ಸ್ಟಾರ್ಟ್ ಆಗುತ್ತೆ. 8 o'clock ಬರ್ತೀರಾ? ಹೌದು, 8 o'clock ಬನ್ನಿ.
So, as we know that once you call extreme risk group, this means the patient has an ASCVD. So, ASCVD with diabetes may fall into category A. Now, these are some of the statin trials where the patients were divided into 2 groups, those patients with CAD with diabetes, and second was CAD without diabetes. If you look into the CARE trial in which pravastatin was used and mean LDL cholesterol achieved was 98 milligram, you can see those patients of CAD without diabetes, the incidence of events were 19.4%. And when patient had underlying diabetes also, the event went up to 28.7 at same mean LDL of 98. And if you look into the TNT trial with 80 milligram of atorvastatin, the mean LDL cholesterol achieved was 77. The incidence of events were 7.8% in patients without diabetes, and it was 13.8% in patients with diabetes. That shows the mere presence of diabetes with coronary artery disease, the events goes up at any level of LDL cholesterol, like for example here at 98 or 77 milligram. Now in the IMPROVE-IT trial, in which the achieved LDL cholesterol was around 53. So we have seen at 98, we have seen at 72, and now 53 again. Those patients for CAD with diabetes had more event as compared to those patients who did not have diabetes. And if you go into another trial, 4-year trial, in which those median LDL cholesterol achieved was 30 milligrams, those patients with diabetes had 14.4% event as compared to those patients without diabetes, where the events was 11.4%. That again just gives strength to our thought that association of diabetes with coronary artery disease events are more. Now, question comes to why there is a need for a category B. What is the category B? Now, we have seen that at any level of LDL cholesterol, CAD plus diabetes, there is more events with this combination as compared to diabetes alone or CAD alone. But if there is a patient of diabetes plus ASCVD, the events will become more if there is an associated comorbidity. Means CAD plus diabetes plus comorbidity, events will be more than patients who have ASCVD plus diabetes. Now, for example, in IMPROVE-IT trial, those patients of CAD had 30% event in 7 years' time, and it increased to 40% when there was associated diabetes, and it jumped to 56% when there was an associated peripheral artery disease. Another example, this is the acute myocardial infarction patient who underwent PCI. At 12 months' time, if you look into the outcomes, those patients with CAD only had 5.5% event. With diabetes, it jumped to 15.6%, and when there was associated hypertension, it further climbed to 18.7%. Now, another IMPROVE-IT trial, analysis of IMPROVE-IT trial, in patients with diabetes, these are patients of diabetes plus ASCVD, when there is no or one risk indicator. These are the 9 risk indicators you can see, which are congestive heart failure, hypertension, age more than 75, diabetes, prior stroke. If none or one of these was present, then the events were 11.7% at achieved LDL cholesterol of 53, and it went up to 16.6% when 2 of this risk indicator was present, and it jumped to 36.3% when 3 or more of these risk indicators was present. That shows that higher the associated comorbidity with ASCVD and diabetes, higher are the events. So this means you cannot have same goal of LDL cholesterol, same target of LDL cholesterol in this patient of ASCVD and diabetes, or patient with diabetes, or patients with ASCVD. It's not a uniform group. It is heterogeneous, and you have to decide, considering what are the potential, incidents of cardiovascular event with a particular clinical scenario. Now, coming to LDL cholesterol goal of less than 30 milligram, and when we published in 2020, many of our friends, they didn't agree to it, but this was based upon a strong scientific evidence, strong scientific studies. Now, remember one thing, that if you reduce LDL cholesterol by 40 milligrams, from any level of LDL cholesterol, you reduce major adverse cardiovascular event by 21%. And if you reduce LDL cholesterol by 20 milligrams, you reduce major adverse cardiovascular event by 16%, 13% decrease in coronary death or non-fatal myocardial infarction. We published about LDL cholesterol of less than 50 milligrams in patients with very high risk group in 2016, which Dr. Vimal Mehta also discussed. So if we reduce LDL cholesterol from 50 to 30, we expect 16% reduction in major adverse cardiovascular event or 13% reduction in coronary death. That was one of the bases for it, because this is based upon CTT meta-analysis when high-intensity statin was compared with moderate-intensity statin in patients with ASCVD. Now, to add to the strength to our thought process, we had result of 4-year trial in which the LDL cholesterol median from basal of 93 was reduced to 30 milligrams, and there was 15% reduction in primary endpoint. And there were 3 important post-hoc analyses. One of that was Odyssey trial, in which there were about 770 patients who achieved LDL cholesterol of less than 15 milligram. When they were compared with the propensity matched placebo, there was 21% reduction in event in 4 years' time. And another post-hoc analysis of IMPROVE-IT trial, where about 6% of patients achieved LDL cholesterol less than 30 milligram, as compared to more than 70%. 70 milligram, there was 21% reduction in event. And then in 4-year trial, there were about 2,000 patients who had a median LDL cholesterol of 66 when it was brought down to 21 milligram, and there was 30% reduction in event. And Dr. Vimal also discussed about lowering LDL cholesterol to ultra low level of 10 or 20 milligram. In 4-year trial, there was significant reduction in event in those who were less than 10 milligram with a median of 7 milligram also, there was significant reduction in event. 1 year after our recommendation, the National Lipid Association also came out with a statement for prevention of ASCVD in South Asian living in the United States. And they also recommended an extreme risk group with a goal of LDL cholesterol less than 30 milligram in patients with ASCVD and diabetes. Now, question comes that if we saw that about 14.4% of patients of diabetes, even with an ASCVD, they had even despite achieving LDL cholesterol of 30 milligrams. So this means we have to look beyond LDL cholesterol now and look into the other lipoprotein like triglyceride and non-HDL cholesterol and lipoprotein small a. And here again, I want to emphasize that while you are treating patients of diabetes, you must make sure that you are treating all modifiable risk factors. Number one, you have excluded the secondary causes of dyslipidemia, because you may not be able to achieve target if you have not treated the secondary dyslipidemia, because they may be the cause for persistently high LDL cholesterol despite giving maximum drugs. Now, coming to the triglyceride, it has always been a point of controversy and hot debate, but I'll give you a short summary of it. There are meta-analysis of 5 trials in which fibrates were used, and it was found that those patients who had triglyceride less than 204 and HDL more than 34 milligrams, there was only 6% reduction in primary endpoint. But when a subgroup of triglyceride more than 204 and HDL of less than 34 were analyzed, they found there was 35% risk reduction in event. And based upon this, strength trial was there. The PEMA-FABRIC trial was also used. There we did not find any positive, outcome, except that there was some benefit in patients with non-alcoholic fatty liver disease. But the triglyceride hypothesis, was really worked in reduced trial, where it was found that those patients who are persistently high triglyceride more than 135, which those patients who are adequately treated with LDL lowering drugs with a median LDL cholesterol of 75 milligram, it was found that there was significant, and those patients of coronary artery disease or diabetes with one or more risk factor, it was found there was significant reduction in primary endpoint and the secondary endpoint. Not only in that primary and secondary endpoint, there was significant reduction in cardiovascular mortality by 20%, which is almost equivalent to what mortality benefit we have seen in patients who were given statin. So what LA recommends regarding triglyceride is that you should try to keep the LDL triglyceride below 150 milligram, preferably around less than 100 milligram, and always go for aggressive lifestyle intervention and rule out secondary cause, because alcohol contributes to increased triglyceride, uncontrolled diabetes contributes to increased triglyceride. It will be difficult to control unless you control these possible potential mechanisms. Now, triglyceride, we are talking because we are all concerned about triglyceride. But if you look into the target, triglyceride is never a target. Non-HDL cholesterol is a co-primary target. If you control triglyceride to less than 100, non-HDL cholesterol will be also to the target. Or if you control non-HDL cholesterol target, you'll be able to control triglyceride. So our emphasis is that triglyceride make you to worry about the possible cardiovascular event in future. But indirectly, it tells you that you should calculate non-HDL cholesterol and try to achieve non-HDL cholesterol as per earlier recommendation. Now coming to ApoB, in our 2024-23 update, which will be published shortly, we have made ApoB, included ApoB as a secondary target, but it is extremely important to go for ApoB in patients with obesity, metabolic syndrome, diabetes, those with very high triglyceride concentration, or those with very low LDL cholesterol, because there can be discordance between LDL, non-HDL cholesterol, and ApoB. So those patients in which ApoB still remains high, despite LDL cholesterol and non-HDL cholesterol to the target, we should be more aggressive in bringing down the ApoB to the target. Remember, each atherogenic particle carries one ApoB. So number of ApoB means circulating atherogenic particles in the circulation. And type 1 diabetes are also increased risk and it should be treated the way we treat type 2 diabetes. Now, there are international guidelines like American Diabetic Association. They talk of fixed dose statins like moderate intensive statin in patients with age group of 40 to 75, and in those with diabetes with multiple ASCVD with high intensity statin, which I have already discussed in detail. You cannot have the same dose for all the patients because all patients are different. So you have to have a different combination of drugs when we treat patients with diabetes with other comorbidities. And similarly, in patients with CAD with diabetes, they recommend high intensity statin. And as I've discussed that you can have diabetes, ACVD with CKD, post-CBG, stroke, the LV dysfunction. So when all these comorbidity are present, you cannot fix that you will give a fixed dose of high intensity statin, which will take care of cardiovascular event in all these patients. And American Association of Clinical Endocrinology, they also have 3 different criteria. Those with diabetes with no major ASCVD risk factor, they have recommended LDL cholesterol goal of less than 100 milligram, age less than 40 years. Remember one thing that by 40 years, about 40% of patients of cardiovascular disease or coronary artery disease have already dead in an Indian population. And 25% of the patients who get myocardial infarctions are less than 40 years of age. So you cannot wait for 40 years or beyond to start treatment for diabetes when we know that diabetes has a strong association with cardiovascular disease. And most of the patients of diabetes, they die of coronary artery disease, and diabetes in Indian population starts much earlier, somewhere around 25 to 34 years of age. So I think that age is one of the factors by which we differ from international guidelines, and also their goals and targets we differ, and also they have fixed goal for for all comorbidities. Like for example, diabetes with CVD, according to American Association of Clinical Endocrinology, falls into extreme risk group. And they have set goal of less than 55. Now, for example, a diabetic patient has CVD, he has CKD, he's a post-CBG, he has an LV dysfunction, and he has so many other comorbidities. You cannot have the same goal of less than 55 for all. And the European guidelines have updated revised their recommendation for diabetes, and this is the latest 2023 lipid guidelines for diabetes from European Society, in which they have classified very high risk group as those patients of type 2 diabetes with clinically established ASCVD or severe target organ damage or 10 years of CVD with more than 20% using score 2 diabetes. Now, question comes then, if all 3 are present in patients with diabetes, will you have the same target? Answer is no, because I have explained you, in detail that higher association of comorbidities, increased number of comorbidity increases cardiovascular event, and lowering LDL cholesterol reduces cardiovascular event. And even the latest ACC 2022, they have considered diabetes with coronary artery disease as very high risk, and they have also gave target of less than 55. Again, the same limitations which we have been discussing before also. So the take-home message is that we should start statin on the day diabetes is diagnosed, decide diabetic patients ASCVD risk category, and achieve LDL cholesterol, non-HDL cholesterol, an ApoB target at earliest as recommended by LAI, preferably by week 8. Screen Indians for diabetes, pre-diabetes, other ASCVD risk factor, including lipid profile, which should include lipoprotein small a and ApoB level, if possible, at least 20 or earlier if indicated. Good glycemic control in addition to lipid lowering drug is important to achieve lipoprotein targets. Lifestyle intervention is very important. Treat all modifiable risk factor as per respective guidelines. Thank you very much for your kind attention.
Thank you, Dr. Amanpuri. I think you have practically covered, the every point in lipid management, particularly in diabetes, and you have given us very clear, the sort of a consensus how to manage, and you also showed in how, the target based on the risk. Like you have very clearly said how European American keeping just less than 55 as one target, unlike what you have discussed. When you got a multiple comorbidity, you can't have one size fit all, So you need a separate risk characterization, and therefore rightly LAI has put, extreme risk category A, B. Maybe, I don't know, you didn't put there. Maybe you will put later. I think it's not yet published. Iyengar, you want to make few comments before we take panel part? Both the essentially, both the topic ultimately were like a target. Whether unmet target, with our high intensity as it may be, question of using bempedoic acid, and secondly in diabetes dyslipidemia, again the target what Dr. Puri said. You have any comment? Few minutes, and then we'll take the panel discussion.
Yeah, those were two very excellent talks. I must mention that I think Vimal started with a bank statement saying that is a masterstroke, I think, for all of us. It's an epic failure that we have not been able to achieve our goals despite all the medicine that are available with us, all the medicine that are available with us. One or two things about bempedoic acid. One thing is we should not take bempedoic acid as an alternative to statin. It's only in those patients who are statin intolerant or you want to have an additional drug, then it is okay. And secondly, it didn't show any difference when it came to stroke, all-cause mortality, and cardiovascular mortality, probably for the reason which Vimal mentioned. One is the duration of the study was short, and secondly, the accompanying pharmacotherapy, other sort of treatment was very aggressive. So you can't demonstrate the benefit on the mortality. And of course, other possibilities probably didn't have any effect. So this probably time will tell us what is the thing. Then other point, of course, Raman mentioned about BMI being more or less lower in our South Asian person. But what is more important is the central obesity or the waist measurement, which hardly any of us measure. Now, other things we all talk that, you give statin, high intensity statin, and add ezetimibe, add bempedoic acid, add PCSK9. And there are some patients, as mentioned in a limited manner, that they are the patients of familial hypercholesterolemia who do not respond to any of these drugs. Then, of course, the option left for them is either to go for lipoprotein apheresis or other drug which is not available at the moment is evinacumab. Of course, other things they would have shown because of time of shortage, the regression in atherosclerosis will happen only at very low levels of LDL cholesterol. So we have to be very aggressive in our lipid lowering therapy.
I think, the very important point what Raman Puri in the last slide mentioned, which is important for the delegate, that we need to pick up all these, lifestyle diseases at very early age, like, as he rightly showed, our LA recommendation by the age of 20 or earlier, possibly doing lipid, checking the blood pressure, checking the, the diabetic status, because even in a pre-diabetic, there are high incidence of ASCVD, that it could be an indication to start statin even a pre-diabetic. Like, Dr. Puri in the last slide also said, for all diabetes, moment they diagnose, we have to put on statin. Here, I would like to just mention the delegate because that fear of, statin-induced diabetes. Personally, for me, this type of fear we have to remove from the head. So long as we are giving statin for a diabetic patient, now statin inducing diabetes, which is like a chemical, is not the same as, what is diabetes de novo we are getting. That is one thing. And plus, Jupiter trial, Paul Ritker has very clearly mentioned or shown that this pre-diabetic individual, like, overweight, family history, they are prone to get diabetes due to statin. In fact, one simple study wherein they taken about 250 patients for 4 year study, and in 4 years they have found out of these 250 patients, only one got the diabetes, whereas 5 vascular events were suppressed by statin. So, what do you say about this? And I want very clear comment because time and again, this statin, I agree. Higher the intensity, higher the dose, all side effects of statin are to some extent dose related. Whether you talk about diabetogenic effect or whether you talk about the muscle side effect and things like that. Now, the statin-induced diabetes, are we really have to fear today? That's the thing. Each one make a comment of this one. Starting with Dr. Puri, what do you say about it?
I think statin only prepone diabetes. By approximately 5 to 6 weeks. That is based upon the trial, which is that. And second thing, which I say that the patient who becomes diabetic with statin should be, they are fortunate patient, I say. You say, why fortunate? Because we have started statin in pre-diabetic phase of these patients.
Yeah.
And the event have been, it has been found in which trial it was that, I'm forgetting the name. It was found that for 65 newly diagnosed diabetes, there was 134 events which were prevented. Yeah. During pre-diabetic phase, I'm talking about. So I think that those who become diabetic, they were ultimately they will be diabetic. Only thing that it has been preponed by a few weeks only. So I think one should not worry because the event reduction is far more than what the number of that get. So I think that should not be. Rather, I say that forget about diabetes. If patient requires ASCVD, patient with ASCVD, you should worry about cardiovascular event reduction. And even if the patient becomes diabetic, you have that patient is fortunate to have statin before he became diabetic. So I think that should not be a concern at all.
What about Iyengar, your comment on this?
Yeah, I think Dr. Mandi has very clearly said it usually produces new onset diabetes in patients who are already prone to develop diabetes.
That's what it is.
And interestingly, there are only two lipid lowering drugs which sort of produce new onset diabetes or worsen diabetes. One is nicotinic acid, and another one is the niacin, and the other one is the statin. Whereas bempedoic acid, ezetimibe, PCSK9 inhibitors, BSA, they have no problem with the diabetes at all.
The good thing about bempedoic, which Vimal has showed very clearly, that AMP activation is very, very important, and that also is important, like many of the drugs, like one drug is metformin. So bempedoic, activating the AMP, and that is why, has got a diabetic friendly or the issue, and which Vimal has shown during his presentation also. Vimal, what do you say about, that fear, because time and again, even today, or maybe tomorrow, again, the same thing, I get time and again, statin-induced diabetes, this type of fear.
Sir, Dr. Raman said, and I agree with him, that the pre-diabetes, as far as cardiovascular risk is concerned, cardiovascular risk of diabetes is concerned, pre-diabetes is as bad as chronic diabetes. That is one point which has already been mentioned. Secondly, in most of the studies, like 4-year study mentioned 27,500 patients, sir also mentioned, 40% patient were diabetic and 40% were pre-diabetic. So, meaning thereby that most of the patients who have cardiovascular disease, especially in secondary prevention, they are already, I mean, they are high risk cases. So they have to be treated. And the risk of, as mentioned, it basically preposes the conversion of pre-diabetes to diabetes a little bit more. That is one point. Secondly, starting of statin therapy may be a marker or sort of inducer for the patient to be more aggressive as far as other lifestyle measures are concerned. Now that they are on drug therapy, that they have to be more particular about other risk factors like smoking, alcohol, and so on, exercise, weight reduction, less of a sedentary lifestyle. So I agree, people will be concerned, but this is there. Secondly, this risk is more with the high intensity statin compared with the low intensity statin. Why this is important? Because even our algorithms state that patients who are at low risk or so, low to moderate, somebody is 50 years, not many risk factors, we consider them a low risk as per algorithm. So they may be started on low to moderate intensity statin, where the risk of diabetes is much lower compared to full dose statin therapy or high intensity statin therapy. So these are, I mean, this is all I have to say, sir.
I think that if you can say, I can simplify it. For if you treat 1,000 patients with moderate intensive statin, you induce one diabetes. There will be one diabetic patient. Whereas with high intensive statin, you have to treat 500. You treat 500 patients, there will be one diabetes. That is all the difference between moderate intensive statin and high intensive statin. I still will strongly say that one should not bother about diabetes because
that's what that I agree with Dr. Puri. In fact, I make a very candid statement all the time. I don't just treat first diabetic as a vascular disease. Don't worry about that little chemical sugar going up. Even if it happens, we can easily treat today. And as such, we are recommending lifestyle modification, etc. And in addition to that, if required, anti-diabetic can be given, but statin we can't just avoid it. Only other point I just want to discuss with you people, since they are in the same pathway, bempedoic and statin. So when we are talking about a triple combo, say 40 milligram Rosuvastatin, 80 of Atorva plus bempedoic, and as it may be, maybe the effect of LDL lowering will not be as robust as without this thing. So how to take care of that? Anything? Should we recommend maybe 10 to 20 milligram or something like that? Anything like that? Vimal, you have showed that, with all our clear, with statin or without statin in all heterozygous hypercholesterolemia, etc. With statin, roughly about 15%, whereas without statin, say about 20 plus, 20 to 25, whatever,
Yes,
so that additional 6-7%.
So, sir, the one way to go and what we follow over here is that because we are done with the 80 milligram of atorvastatin, despite Dr. Raman Puri and at my level, I mean, we have been together many times. So 80 milligram, it has been very difficult to tell our physician friend that you have to go 80 on a long-term basis. So the best way to go when I do procedure and all that, over there only, based on if the patient has a lot of disease here and there also, we do one stent and there is some plaquing other vessels also. I straight away recommend 40 milligram of atorvastatin along with 10 milligram ezetimibe straight away. Yeah. Because thereby LDL reduction will be a little bit better. And the compliance will be better. But plus the combination costs less actually. The combination costs less at market level also compared to full dose of 80 or 40 Rosuvastatin.
But I'll add one point to it. See, you have to decide about the dose and the drug combination based upon what percentage of LDL cholesterol reduction you require. We have an ongoing study on triple combo, which means 80 milligram of rosuvastatin, 40 milligram of rosuvastatin, plus 10 milligram of ezetimibe and 180 milligram of bempedoic acid in patient with ACS. It is given at the time when patient is admitted along with the dual antiplatelet. And we have seen a remarkable reduction in LDL cholesterol reduction as high as about 65 to 70% in 2 weeks time. And 70% of patients did achieve LDL cholesterol less than 50 milligrams. What I want to suggest that don't be scared using these combinations because they are safe drugs. Statin we have using for the last 40 years, 35 to 40 years now, azetamide for the last 20 years, and bempedoic acid, of course, recently we have started using it. But always try to achieve the target. I think number of drugs should not matter when you decide about treating any patient with either primary prevention or secondary prevention. We should always look for.
Lastly, one small point which has been time will tell whether combination of statin plus bempedoic acid will result in reduction in the risk of induction of diabetes or new onset diabetes. These statins.
Yeah.
It may be that if we combine both of them, then the ultimately the beneficial effect of bempedoic acid, as such said, there's AMP kinase activation, and it will be counterbalance sort of, and we may have no diabetes in the end.
But only my personal opinion, Vimal, because important place for bempedoic still is statin intolerance that way.
Yeah,
and then as we rightly recommend LAI recommendation acute coronary syndrome. Starting with high intensity azetamib, repeating, extendedly for 2 weeks, and then adding bempedoic or maybe PCSK, depending upon the requirement. So it's very clear that, we have, as you also mentioned, that azetamib comes before that.
Yes, no doubt in that.
Point is that today bempedoic we have got available, and because it is, no muscle thing, which is also reality. I must also say you may not get really, but some people like SGLT2, not really they get into urinary or genital inflammation, but they're not able to, that quality of life do suffer, all those genital area, irritation, itching like that. So also with the statin, myalgia, muscle pain, some patients, it is, really, it's not like a nocebo effect, but really it is, not tolerable. So 1 in 10, maybe a little less than 1 in 20, you may have a place where statin just can't be given, So those a situation again. So therefore, my, the thinking at 40 milligram Rosuva with bempedoic combo available, generally, whether it is a really good synergistic for the LDL lowering, unlike, 40 of Rosuva or 80 of Petrova with 10 milligram azetamib, that way. That is the only, sort of, combo therapy, So that's the only probably, as you said, time may probably tell us, etc. Anything, there are some questions about the uric acid problem, fracture, tendon, this thing. I don't think they're the very, very huge problem, I feel, personally, There were some questions in chat box about this, about the creatinine going up a little bit, or maybe uric acid, etc. How do you find that, Vimal? Maybe elderly people or CKD patients.
Sir, first of all, there are multiple questions. One by one, the uric acid, as per the trials show, goes up by about 0.7 milligram per deciliter. So somebody who has had an episode of gout or who has some pains but not directly diagnosed with gout, it is best avoided with monitoring of uric acid. Maximally, it will go by 1 milligram per, but this is in a large population, in a large number of patients when you prescribe. So maybe 1 or 2 or 3 in 100 will go beyond that line and go cross that line and go into a symptomatic stage of gout and all that. So we guidelines also mentioned, LA position paper also mentions that uric acid should be monitored at seen at baseline. If it is above 7 or so, then it may be repeated and symptom-wise. So it is very negligible. So those patients you have to avoid. Creatinine again goes by very minimal. It is because of the organic anion transporter to inhibition. So it is not a concern. As far as CKD is concerned, or for that matter, children are concerned, so those subsets have not been extensively studied. In mild to moderate renal dysfunction, GFR about, let's say, 40, 45 or so, above that, you can safely give. Below 30, you should surely avoid it, because it has not been predominant, it has not been studied. And 70% is renal excretion. So this is about it, sir. I missed out some questions.
Yeah, no, it's okay. Yeah. Dr. Puri, just recently, just few days back, one article in ESC journal, the triglyceride importance and, the management. In the primary prevention, they did mention fibrates. Secondary prevention, they mentioned ISC, that is the recursive pentaethyl. Now, we also recommending, better to keep less than 150, but optimal is 100. And now you say triglyceride more than 500, because they will question a diabetic individual, high triglyceride, but LDL is, near normal or mildly elevated. Now, LDL, it means, probably not small dense LDL, because you can't, by the LDL report, you may not get just HDA, how much is the small dense. But a suspect is a typical diabetic, heterogenic dyslipidemia, where high triglyceride, low HDL, and increased small dense LDL. So how to manage, that's what is the question, here. So, and this is a reasonably, and which you have also shown in your that, in children study 2015, what you report in AC, Jack, So how do you address this issue?
See, if you have high triglyceride with diabetes, no doubt you have to start with the statin. Statin is very important unless triglyceride is more than 500, where fibrate becomes important, because you have to prevent pancreatitis. That is the most important part for us to reduce that. Number two, lifestyle intervention plays a very important role in triglyceride lipoprotein, because you can reduce it by as much as 50%. That is extremely important. And one should always rule out secondary cause. Alcohol is very common. It's possible reason for increased triglyceride. So once you exclude all the possible potential cause for hypertriglyceridemia, you have patient is already on aggressive lifestyle intervention, and the triglyceride is less than 500. Then of course statin is the first drug to be used. Fibrate will not be a drug which is to be used first, because statin also reduces triglyceride by 25 to 30%. Higher the triglyceride, greater will be the percentage reduction in triglyceride by statin. So statin is the drug to be used, and you should try. And another important thing, that with high triglyceride, you always underestimate LDL cholesterol. So the best thing will be to go for a direct LDL cholesterol rather than calculated, because calculated is not done if the triglyceride is more than 400. So that is important. So once you are you have brought down, you have given high intensity statin, you have brought down the LDL cholesterol to the target, and the triglyceride still remains. What LA recommends is fibrate is the first drug which you should use. See, the fibrate is a very unfortunate drug because of various reasons. It's still it is a useful drug, because it does reduces ApoB by around 8%, and also it reduces LDL cholesterol to some extent. So you always have an additional benefit of LDL lowering with fibrate, which is not there with icosapent ethyl. But the result of icosapent is much better, because it reduces cardiovascular mortality by 20%. There is a significant reduction in primary endpoint, which has not been documented with fibrate at present. So overall, what we recommend is that when the triglyceride is high, the fibrate still remains an important drug to bring it down. But if, for example, triglyceride is somewhere in the range of 150 to 200 and 250, because overall icosapent ethyl will reduce LDL cholesterol triglyceride by around 19% to 20%. It's not going to reduce this more than 20%. So you can substitute fibrate for icosapent in patients with ASCVD or diabetes with multiple risk factor if the reduction is not much. If you require about 20% triglyceride reduction, But if it is much more, triglyceride is more than 500, probably icosapent will not be a drug of choice.
Yeah. That's why the question was asked here. Icosapenta is basically as a secondary prevention, and that also, as you said, cardioprotective or more of a vascular drug rather than a TG lowering. So here again, I think fibrates have got a role. I think it's important. Like our LA has given sometime I hear and I sometimes see in the other organization no fibrates at all. It's totally like which I disagree. What you say, Dr. Iyengar? Because when you talk about non-HDL cholesterol, second co-primary target, we mean all this. In fact, yesterday I was just hearing Dr. Kaushik Ray's talk, and it mentioned that among the LDL which goes into the vessel, triglyceride containing cholesterol goes inside the vessel, and LPA, the three way it can go in. So how do you find that part? Your non-HDL.
No,
What I'm saying is the triglyceride part point of view.
Yeah, non-HDL, of course, non-HDL cholesterol is easy to find out, total minus the HDL cholesterol. As Raman mentioned, we must aggressively treat the LDL cholesterol. It comes to normal or the targets. Then if the triglyceride is still high, then I think there is a role for fibrates. And that's what I think we have been recommending. And if it is secondary prevention, probably then you can add the omega-3, the icosapenta. And icosapenta has already been mentioned. It acts not more mainly by the triglyceride lowering, but the other actions like action on endothelial function and plaque stabilization, etc. And the high triglyceride indicates that probably his triglyceride-rich lipoproteins are high. So there's a direct, indirect indicator that is high, and you have to take all these treatment. And as you rightly mentioned, the only things that are ApoB containing particles, that is non-HDL, then ApoB and LPA, and triglyceride-rich lipoproteins. They are the ones which can enter the intima and initiate the process of atherosclerosis.
Dr. Sadanand, I will like to make some comments that triglyceride without cholesterol will never cause atherosclerosis. You do require cholesterol molecule for atherosclerosis. Why triglyceride-rich lipoprotein like chylomicron or VLDL remnant are highly atherogenic is because though the process of atherosclerosis is started by cholesterol component of these particles, but triglyceride means fatty acid which are released in the arterial wall. They cause intense inflammation. As a result of that, the atherosclerosis process is accelerated, and you have more severe form of coronary artery disease as compared to those which is induced by only LDL particles. So triglyceride per se without cholesterol will never cause atherosclerosis. That is very important for us to understand. Therefore, treating non-HDL cholesterol is extremely important because it contains all the cholesterol content of triglyceride-rich lipoprotein. It contains it includes cholesterol content of LDL particle. It includes the cholesterol content of lipoprotein small a, intermediate density lipoprotein. So if you bring LDL cholesterol to the target and non-HDL cholesterol to the target, I don't think that we should worry much. And in case you can do control ApoB also, that will complete our treatment of dyslipidemia. So that is most important. Bring down LDL cholesterol to the target, non-HDL cholesterol to the target, and ApoB to the target.
Dr. Puri, just continue. There's a little link problem. Just continue because can you hear me?
Yes, we can hear
just you. I'm just reconnecting. Till that time, yeah. What you mentioned about, yeah.
We can see you and hear you.
Yeah.
There
was some problem in my. You can hear me?
Yeah. Connected two places. You're logged on to two.
Yeah.
This is okay. Yeah.
You can hear me now, isn't it? Kapil, you can hear me?
You have to log out from the other one. Otherwise,
So you can log out from mobile.
No, I logged out. I logged out.
Not yet.
Yeah.
Yeah.
Can you hear me now? Kapil, any more thing? Maybe now it's a time to, it's almost done, or you have got anything to make? Otherwise, I will just summarize the our webinar, and that's okay.
Yes. Please, sir.
Yeah. We had a very clear, the consensus on, like what Dr. Vimal mentioned, what is the unmet need LDL-C lowering and how bempedoic acid can help us. And Dr. Puri rightly mentioned in diabetes dyslipidemia, how we should be treating. Essentially, in both the topic, the key, which is very clearly shown, is the application of simple arithmetics. It is, trying to find out the risk and then getting the target. How to get the target, whether, single statin or combo, as it may be, or with the bempedoic, or whether along with that PCSK, is all depends upon the number of, risk factors and what target you are going to achieve. Now, also for the delegate, all of these consensus are available in our website. You can click website lipid.net.in and you will get all the consensus. And if any query, you can write to LAI and we can get all the detailed information. And I must really confess, today we had a feast of information on this very, very important topic. And our whole idea is to see how we can perpetuate, create awareness. And that is where, we need continuous help from JB Pharma. And with this, I would wind up, and I must like to thank Dr. Raman Puri, Dr. Vimal Mehta, and Dr. Iyengar for joining this session. With this, I will hand over to you. Om Prakash, you want to say something, or Kapil, you have to say something?
Yeah, sir, I think I will offer the vote of thanks to Mr. Om Prakash.
Yeah.
Thank you, Dr. Kapil. Good evening, sir, and good evening to all respected faculties and speakers. I think, sir, it's been a privilege to host second webinar in collaboration with LAI, and we are getting definitely good responses, sir, from our side. So I think what we are also gaining a lot of insight for us as a company, because for us statin is a new journey altogether. So we get a lot of insight, and then we again go back to our HCPs and share what are the key learnings out of it. So thank you so much, sir, for giving this opportunity to partner with LAI for JB Pharma.
Any number you want to announce? How many people join?
Yeah. I'll just say. So 2,000 logins we have in YouTube, and 1,035 is the latest number in Zoom link that we have. So close to 3,000 plus HCPs have been logged in, sir. So I think in light of so many events happening.
I agree. I agree. A big number.
Yes, sir.
So good people for good health.
Right, sir. And it's all possible because of your support, sir. And thank you for helping us to drive this. Thank you, Dr. Puri, also. I can understand, sir, he's traveling a lot, but still is making time out and giving us this opportunity. So thank you so much, Dr. Puri, also. Thank you so much, Iyengar, sir. Your presence definitely makes that entire interaction, very, very healthy and productive for all the HCPs. And Dr. Vimal Mehta, thank you so much. And definitely my team would have reached out. I think I got that query. So team is reaching out to everyone, sir. And thank you so much for your support here. I think, sir, it's been a great collaboration, I would say, sir, in terms of reaching out and sharing the all articles and presentations on time. So it's a great collaboration from entire JB team and LAI team also, sir. So I would like to say thank you to each one of you for giving this opportunity. And looking forward for more 2 sessions with LAI going forward.
Thank you.
Thank you, sir. Thank you.
Kapil, anything to add?
Yeah, no, sir. Thank you, sir. Looking forward to have more associations with LAI.
We are ever ready. We are ever ready. Om Prakash will tell me which is the next date now.
Yes,
Right.
yes.
Session 3 or something. Yeah. Thank you very much. Okay, bye. Thank you very much.
Thank you, sir.
Thank you,
Thank you
Dr.
so
Puri,
much.
Right,
Vimal,
right.
and Iyengar.
Thank
Thank you very much.
Good night.
Thank
Okay,
you.
okay,
Thank you.
fine, fine.
Right, sir.
Thank you.